Chairperson-elect Dr. S.S. Rawat sir, respected senior faculty member Dr. Kabra sir, other faculty member Dr. Tanu Singhal, Dr. Ankit Parikh, and today's moderator of the session, Dr. Kamal Singhal. So, welcome to this webinar on pediatric tuberculosis on the occasion of World Tuberculosis Day, which is scheduled on 24th of March 2024. So I invite Chairperson IAP NRC Dr. N.K. Kalpnawar sir for formal welcome. Dr. N.K. Kalpnawar sir.
Good evening all. At the outset, I take this opportunity to welcome, first of all, I welcome all the office bearers, Dr. S.S. Rawat sir, President-elect, and Dr. B.S. Sharma sir, immediate past President, Dr. Jagdish Goyal, and Dr. Mukesh. So today we have a very important day celebration, that is the World TB Day celebrations. So this is one of the most important burning issue for all of us. And we know that we have today a very eminent faculty members, and they doesn't need any introduction. And first, I take this opportunity to welcome today's moderator, Dr. Kamal Singhal, for this very important webinar session. And I'll take this opportunity to welcome the other faculty members for today's sessions, especially Dr. Kabra sir and Dr. Tanu Singhal and Dr. Ankit Parikh. All are the senior most pulmonologists of the country, as well as they are very, very experienced in the field of pulmonology, especially in the tuberculosis. So without much ado, I welcome all the faculty members and the moderator and all the delegates. Today, you are going to have a very important sessions on tuberculosis. This is very, very, we all know that this is badly needed for elimination of tuberculosis in our country. I take this opportunity to welcome you all once again, and I hand over to Dr. Jagdish Goyal.
Thank you, sir. Thank you very much. Now I request today's session moderator, Dr. Kamal Singhal, to introduce the faculty member and start the proceeding. And we will take the question at the end of all three lectures. Dr. Kamal Singhal, please.
Welcome everybody. So today we have very with us, Professor Kabra, knows no introduction. She is a consultant pediatrics and infectious diseases in Ambani Hospital, and Dr. Ankit Parikh. Please start the presentation, and she will discuss a very burning question for the day these days, the drug-resistant TB. So over to Dr. Tanu Singhal.
Okay. Is my screen visible?
Yes, ma'am. The slides are.
So I would first like to thank Dr. Jagdish Goyal, Dr. Kabra sir, for inviting me to make this presentation on drug-resistant TB in children, which is a topic which is very close to my heart and one that I deal with regularly in my practice. So it is better to start with some definitions. Now, drug-resistant or drug resistance can be primary when a patient gets infected with a drug-resistant strain to begin with, or it can be secondary when resistance is acquired during treatment. Now, in children, most of the drug resistance is primary when they get infected from a DR contact. And therefore, if you control the drug resistance epidemic in adults, the incidence of pediatric drug-resistant TB will come down. We also need to know the definitions of the drug resistance. And monoresistance is when the isolate is resistant to any one first-line drug except rifampicin. And the most significant form of monoresistance is INH resistance. Polyresistance is the term used when there is resistance to one or more first-line drugs, but not both INH and rifampicin, because these two drugs are the cornerstone of treatment of tuberculosis. Then we have rifampicin-resistant TB, which actually makes a paradigm shift in the treatment of TB. And this rifampicin-resistant TB can be either rifampicin monoresistant TB, which is quite uncommon. What is more common is multi-drug resistant TB, when there is resistance to at least both INH and rifampicin. That means both the main drugs for treatment of TB are lost. Then we have what is called as pre-XDR or pre-extensively drug-resistant TB, where you have MDR with resistance to quinolones. And then lastly, you have extensive drug resistance, where you have pre-XDR with resistance to either bedaquiline or linezolid or both. And you can see that there is a change in definition, because earlier we used to term XDR TB as TB which is resistant to quinolones and aminoglycosides. But now, since aminoglycosides are no longer important drugs in treatment of DRTB, that criteria has been dropped from the definition of XDR. So this slide just gives you a bird's eye view of the burden of DRTB in the world and in India and in children. And I won't spend too much time on this slide, but just important to say that of the 10 million cases of TB every year in globally, you have 400,000 cases which are estimated to be drug-resistant TB cases. And what is really shocking is that only 11% of these cases are actually diagnosed and receive treatment. The rest of them continue to transmit the infection and may actually die, because the mortality rate of drug-resistant TB is quite high. When we look at the burden in children, it is estimated there are about 25,000 to 32,000 cases per year, and even fewer percentage of children with drug-resistant TB are diagnosed. This is because it is especially difficult to get appropriate samples in children, and many children are actually treated without a microbiologic diagnosis. When we look at the burden in India, we are estimating about 100,000 to 135,000 cases of MDR TB overall in India every year. And what is reported to NTEP is only about 2,000 cases in children per year. And this is probably a gross underestimate, and the actual figures may be quite high. So it means that as practicing pediatricians, it is possible for us to encounter children with drug-resistant TB in our day-to-day practice. And that is why it is very important to understand this topic. So the first question which arises in our mind is that when should we suspect DRTB or rifampicin-resistant TB? And the first criteria is that when a child who is diagnosed with TB does not respond to first-line drug treatment, and this is a child who has been diagnosed with TB on the basis of clinical or radiologic criteria, but not microbiologic diagnosis. But there are many caveats to this, because there can be other reasons for non-response. First of all, it is important to understand that it may take up to 4 weeks for a child to get better. Then the child may not be taking the drugs. It may not be TB at all. Many of us have seen cases where we make a diagnosis of TB, start treatment, and when the child doesn't get better, we investigate and we find that actually it is some other disease, maybe a lymphoma or something else. Co-infections, which are common in HIV-infected children, can lead to non-response. And then finally, there is this term called paradoxical reaction, when a child who is TB, who has drug-sensitive TB, improves and then worsens again because of the body's immune response. And this paradoxical reaction is actually a diagnosis of exclusion. So these are the things which one must keep in mind when they think that a child is not responding to TB treatment, because drug-resistant TB can only be one of the causes, not all. The second situation where we should suspect DRTB is in a child who has a close contact with drug-resistant TB. And it is a point which is very important when we, when we evaluate any child with suspected TB. Because it is not enough to just ask whether there is somebody in the house who has TB or not. It is important to ask many other questions, that whether that patient has been diagnosed, whether that patient has pulmonary TB, whether any tests are available, is the patient responding to treatment? And earlier, when injectable drugs were being used, it was important to ask whether the patient is on injectables, whether the patient who is a contact has been taking his medications regularly or not. Also, it is important to ask about death of a TB patient in the family, because that may be a surrogate marker for drug resistance. And then also, we have to ask about whether there are any HIV infected adults in the family who have TB. So these are the pointers, and if any of these are present, then it would heighten our suspicion for DRTB. The other situations are when a child presents with recurrence of TB. Now, this recurrence of TB can be either be a relapse or reinfection. And in this situation, it is important to ask that when the child had the TB the first time, was the diagnosis made properly, whether there is any susceptibility available, whether all the drugs were taken and which drugs were taken. Because that will also make us know how likely is this current episode drug resistance. And sometimes we actually find that children who come with recurrent TB, the first episode may not have been TB at all. It could have been just some other problem which was treated as tuberculosis. When a child presents with history of treatment default, the risk of drug resistance is high, and the drug resistance in this setting will be secondary drug resistance. And the default occurring in the intensive phase of treatment is associated with a higher risk of secondary drug-resistant TB, because the bacillary load at this time is high. And that is why it is very important that if there is a child who has defaulted on therapy, you have to investigate that child all over again before you recommence his TB treatment. And then finally, if a child has HIV co-infection, the risk of DRTB is higher. But remember, as per the NTEP and the new guidelines, every patient with suspected TB is a presumptive drug-resistant TB case. So that is why in our country, we offer universal drug susceptibility testing right in the beginning, so that we don't miss out on DRTB cases. The only thing is that your index of suspicion is higher in certain circumstances, which I elucidated earlier. So let us say we have a child whom we think could be a presumptive DRTB case, and the approach to this child will actually be the same as we would approach a child with suspected TB. We would, of course, rule out other possible causes for non-response. We would review the drug susceptibility reports of the index case, if there is an index case there, and we would make efforts to get them. And the most important point here is that we have to make a microbiologic diagnosis. Now, you know that when you approach any case with TB, you do make efforts to make a microbiologic diagnosis, but you do your gastric lavage, you do your induced sputum. But if your reports are negative, then you actually go ahead and start empiric treatment. But when you are suspecting DRTB, you will go all out to make a microbiologic diagnosis. And therefore, a clinical examination is very important so that you can pick up nodes. And sometimes you will actually find supraclavicular nodes which are easily biopsied. You have to examine the respiratory system. You have to examine the abdomen, bones and joints. You have to do an HIV test in these patients. And then you do imaging to identify the best site for microbiologic diagnosis. And that imaging can include an ultrasound, it can include a scan, and it can even include an MRI. And then once you know that which system you are dealing with, whether it is pulmonary or whether it is extrapulmonary TB, you will get the appropriate sample. So in a case of pulmonary TB, it will be gastric lavage, it will be induced sputum, or even a bronchoscopic lavage. And if you have a patient with extrapulmonary TB, you will get the appropriate sample. And especially like if it is CNS TB, you'll get CSF. If it is pleural or peritoneal TB, you'll get pleural or peritoneal fluid. If there is a solid lesion, you will biopsy it. And so one thing which sets apart our approach to DRTB is that you will do invasive methods also if required. So if you're suspecting drug-resistant pulmonary TB and your induced sputum and your gastric lavage are negative, you will try and do a bronchoscopic lavage, or you will try and do a CT-guided mediastinal biopsy to get a particular specimen. And why this is important? Because the treatment of drug-resistant TB is toxic and it is complex, and therefore you don't want to make a mistake. Now, once we have the sample, what should we process the sample for? So the first step is to do an AFB smear, and though you might argue that the sensitivity of the AFB smear is low, if it is positive, it helps you even in diagnosing DRTB, because you can actually do a line probe assay on the smear so that you can pick up INH resistance, you can pick up resistance to quinolones, etc. Then you will do a NAT, and this NAT has to be a WHO or an NTEP approved NAT. And the two common NAT tests that we do in the public sector here is either the Expert or the TrueNAT. Now, Expert MTB RIF Ultra is another NAT which is available in the private sector, whose sensitivity is slightly higher than the normal Expert. And if it is available, you can send for it because it may help you in diagnosing paucibacillary TB. You will send the sample for midget culture because phenotypic DST can only be done on the midget culture, and therefore you would send a sample for this. Now, if your smear is positive, you will do an line probe assay, which can be either an LPA1 or LPA2. And you can, because the results of these tests will help you choose the treatment regime for DRTB. And if your smear is negative, then you can do these tests once the culture turns positive, because the results of LPA1 and LPA2 come in 2 to 3 days, unlike the results of DST, which may take 3 to 4 weeks. Now, there is another test which is available in the private sector, which is not approved by NTEP, which is Expert XDR. So Expert XDR is like a combination of LPA1 and 2, and it picks up resistance to INH, but not rifampicin, ethionamide, quinolones, and aminoglycosides. So the only advantage which Expert XDR has is that it's a point-of-care cartridge-based NAT like your Gene Expert, and the turnaround time is short, but it is not approved by NTEP yet. Then you would do a phenotypic drug susceptibility testing once the culture is positive, because you need to know the susceptibility to many other drugs in the regime, like you want to know susceptibility to linezolid, clofazimine, and pyrazinamide, etc., etc. Therefore, you would do a phenotypic drug susceptibility testing. And then last but not the least, in certain cases, you might have to resort to sequencing, but this is not yet there in the commercial platform. It is there in research labs. Now, it is very important to understand the interpretation of reports which you get from your NAT tests. Now, if your NAT load is very high, medium, or low, and if your rifampicin resistance is detected, then it is confirmed rifampicin resistance and you can treat as DRTB. The problem happens when your NAT load is very low or trace and rifampicin resistance is detected. Now, in this situation, if your probability of MDR is high, then you can go ahead and treat your patient as a DRTB case. However, if your probability of DRTB is low, then this may be a false positive and you may have to repeat the test. If your rifampicin resistance is not detected, irrespective of whatever load it is, it excludes rifampicin resistance and the patient may still have INH resistance. And finally, if the rifampicin resistance is indeterminate, then in that case, you cannot infer whether it is sensitive or resistant. Remember, do not confuse indeterminate with intermediate. There's no such thing as intermediate rifampicin resistance. So here, because the load of bacteria is very low, the test is not able to tell you whether it is sensitive or resistant. And in this situation, you will have to repeat the test or you will have to wait for the midget culture and then do a Gene Expert or LPA on the culture. So this is just a algorithm for presumptive DRTB or DRTB case, that you first obtain an appropriate sample, send it for smear, NAT, and TB culture. If rifampicin resistance is detected, look at the smear. If the smear is positive, do first and second line LPA and start treatment based on the LPA report. But more often than not, the smear will be negative. In this case, you start the DRTB regime and you wait for the midget culture report. Of course, you have already taken care of the false positive RIF resistance here. Now, if rifampicin resistance is not detected and the smear is positive, you do a first line LPA to check for INH resistance. If your smear is negative, you will start first line treatment and wait for midget culture. And if the midget culture comes positive, then you can check for INH resistance in that. And then finally, if rifampicin resistance is indeterminate, then you can repeat the sample, you can wait for the midget culture, and you will treat individualized. So suppose you have a very sick child with CNS TB and who has a probability of it being DRTB, and your RIF resistance is coming indeterminate, you may want to treat with second line drugs. Now we have a large cohort of children where your AFB smear is negative, your NAT is negative, your midget culture is awaited. These patients are probable MDR-TB. And here you will make efforts to get a better sample, even if it means invasive procedure like a laparoscopic biopsy. You will refer the patient to a tertiary care center, review the reports of index case if available, and then decide upon treatment based on whether how sick the patient is. And if your midget culture comes positive, then you will do an LPA on the culture and phenotypic susceptibility testing. So such cases actually get referred to the nodal DRTB center, who then makes a decision about what treatment to start. Now, moving from diagnosis to treatment, treatment of DRTB should always be in consultation with an expert. Use at least 4 to 5 medicines which are likely to be effective. Do not add drugs to a failing regime. And remember that the treatment of DRTB has changed over time, and we have new drugs like bedaquiline and delaminib.
Hello, Dr. Tanu Singhal.
Yes. Yes. I have 5 minutes.
Yes.
Okay, I'll finish.
Next 2-3 minutes if you can, so that we give enough time to the rest of the speakers.
Okay.
Thank you.
So now you have to use these drugs, and this is the classification of the various types of second line drugs. You have group A, which are the most important drugs. Then you have group B, which are the less important, and group C. Now remember that most of the regimes are comprised of drugs which are from group A and group B. Now, how do you decide which regime to use? So it depends on many factors. It depends on what is the resistance pattern. It depends on the severity of disease. It depends on the age of the patient. It depends on the past exposure to second-line drugs and the availability of drugs. And therefore, you have two main types of regimes which are available in the Indian setting. The first is the short all-oral regime, where you basically have an intensive phase with levoflox, ethionamide, high-dose INH, pyrazinamide, ethambutol, clofazimine, and bedaquiline. And then you have a maintenance therapy with levoflox, clofazimine, pyrazinamide, and ethambutol. In children below 5, you replace bedaquiline with amikacin. And this is a regime which is only applicable to patients who have non-severe forms of pulmonary or extrapulmonary TB. Whereas the other regime, which is the all-oral long regime given for 18 to 20 months, is for all other kinds of patients, where you basically use linezolid, quinolones, cycloserine, clofazimine, and bedaquiline for 18 months in MDR and 20 months in XDR. Now, bedaquiline is only given for 6 months. And here, if you have resistance to any of these drugs, you replace with other drugs from group C. And this is just to tell you that you have to do a detailed workup of these patients before you start them on treatment. You have to monitor these patients for adverse effects with second-line drugs, because many of these drugs have lots of side effects, and linezolid is top in that list. And you have to follow up these patients carefully, look at their clinical features, look at their vision, check their microscopy and culture, ECG, X-ray, and various kinds of lab tests. And you know, many of these things you don't do when you treat a patient with drug-sensitive TB. And you may have to modify the regime based on response, based on the results of the drug susceptibility test and adverse effects of the drugs. And then lastly, just want to tell you that INH monoresistant TB is a disease, has to be addressed. And in patients, if you diagnose INH monoresistant TB, you have to treat with levoflox, pyrazinamide, rifampicin, and ethambutol for 6 months. And chemoprophylaxis, I think, will be discussed by Dr. Ankit Parak. And so with that, I would like to finally conclude by saying that DRTB in children is an important problem. Remember that every child with TB is a presumptive DRTB case. Suspect DRTB in the right circumstances and make efforts to establish a microbiologic diagnosis and interpret the results of all the tests carefully, and then send the patient to a center which deals with DRTB cases so that the children can receive appropriate treatment. Thank you so much.
Thank you so much, ma'am, for a very nicely presented overview of drug-resistant TB. I think we will take questions in the end. So next, I will request the next speaker for the day, Dr. Ankit Parakh, and I will request Dr. Ankit to directly start with the presentation in the interest of time, and we will take a question at the end itself. Dr. Ankit Parakh.
So good evening to everyone, and thanks to the IAP NRC for inviting me to take this talk. So we'll talk about TB preventive treatment, and we'll discuss what's new in this. So briefly, we'll talk about the change in the definitions which have happened. We'll talk about NTB strategy, right? And this is something which has been talked about for the last few years. And that has led us to, identifying populations for LTBI testing and TB preventive treatment. How do you rule out an active disease? What tests are available for LTBI? And what treatment options do we have? Right, so there has been some change in the definition by the government of India and the WHO. So previously we used to call it as LTBI, or latent tuberculosis infection. People believe that infection, you cannot exactly say whether it is always latent. So now they say TB infection. So that is a change which has happened. And TB preventive treatment is the preferred term for individuals who are considered to be at risk of developing TB disease. And we offer them treatment to reduce the risk. So this is the basic change in the terminology which has happened. So just to revise, like what is the sequence of development of the disease, right? So you have a source case which leads to exposure of contacts, right? So primarily the household contacts, and 70% will not get infected and will not have disease, right? And 30% will get infected, and basically it is basically a balance between the microbiological virulence and the host immunity. Now, these infected individuals can go on to develop a persistent latent infection, or they can go on to develop a primary disease, right? Now, this is the group in which we are interested in. No sort of TB preventive treatment can prevent an infection to happen. The TB preventive treatment can only reduce the chances of an individual from being infected to getting disease, right? So it can just help you out with this arm, right? And the risk of developing a disease is definitely more in young children, especially in infancy. So something like 50% in infancy, 25% in children between 1 and 5 years, and then the risk remains around 5 to 10% lifetime. Now, the key issues which are there when we are talking about a TB infection or a latent TB infection is that these are groups of patients who do not have signs and symptoms of the TB disease, and they are non-infective, right? But the point is that many of these patients, they have a risk of developing an active TB disease, and then they can become infectious. And on an average, 5 to 10% will develop active TB disease over time. That is what we understand. And there has been a sustainable development goal 3 and 3.3 target talks about to end the epidemic of AIDS, tuberculosis, and malaria by 2030. So the paradigm shift has been from a TB control to a TB elimination, and I'll just talk about it, what it means. So TB control is basically aimed to diagnosis of TB disease and rapidly rendering these cases non-infectious and to break the chain of the disease. Right, so this is what the DOT strategy was aimed at. Now, there is something known as TB eradication, which talks that there is absolutely no tuberculosis, right? That is not considered possible. And there is something in middle known as TB elimination, which is something which we want to achieve. So it is a broader concept of TB control, where we want to identify and treat the pool of latently infected individual from whom you might get cases later. And this is defined as less than 1 TB case per million of population. So TB is not eradicated, but it is kept at a very low level that it no longer constitutes a public health problem. So that is what we want to achieve. You cannot eradicate tuberculosis, but you can still eliminate tuberculosis, and hence the name National Tuberculosis Elimination Program. So this is what is happening at the national level. So we initially had a DOT strategy. We moved on to a stop TB strategy. And what we are talking about now is an NTB strategy. So as I said, the DOTS TB strategy was about finding the cases, giving them appropriate treatment, and rendering them non-infectious, right? So it was based on symptoms. So people used to come with symptoms and they were treated, they were diagnosed and treated. Now, as we went along and achieved significant reduction in the number of cases, from 2006 to 2015, there was a stop TB strategy where high quality DOTS was expanded. People started talking about TB HIV, MDR TB, and other challenges. There was also a talk about engaging other healthcare providers like the private sector. And then we are now entering into a NTB strategy where it talks about integrated patient-centric TB care and prevention and intensified research and innovation. And we'll just talk about it, what it means. Now, these are the universal goals which have been, which have been thought to be achieved. So what we want to achieve is basically a 90% reduction in the incidence of tuberculosis by 2035 and 80% reduction by 2030. So this is what is thought to be achieved throughout the world, and 90% reduction in mortality by 2030. Right. So these are the global TB targets which have been published. Now, the National TB Elimination Program is a centrally sponsored program under the Ministry of Health and Family Welfare, and it is managed by the Central TB Division, which is the technical arm of Ministry of Health and Family Welfare. And the vision of the program, and it has been published as the National Strategic Plan NSP for TB from 2020 to 2025. So they talk about a TB-free India with 0 deaths, disease and poverty because of TB. And what they have said is that they want to achieve a rapid decline in the burden of TB, morbidity and mortality to achieve SDG of 80% reduction in the incidence and 90% reduction in death by 2025. So which is 5 years ahead of the global TB targets. However, what we look at is the current data is something like a 3% annual decline in the incidence. And what you need to achieve is almost a 11% decline in the incidence to actually reach these goals, which appears to be a bit difficult. So the NSP and the NTP talks about 3 limbs. One is the prevention, one is detection, and the third is treatment. And there's a huge base which is there, which is based on building, strengthening, and sustaining. So we'll talk about the preventive strategy. But if you look at this base, which is also extremely important, and there's a lot of work which has gone by the Ministry of Health and Family Welfare on this. Now, what we understand is that it affects 1/3 to 1/4 of the population, and that is a very big reservoir of active infection, especially in developed countries, right? Because the reinfections are not as much as what happens in India. Now, the treatment of LTBI or TB infection actually entered the WHO recommendation with the NTB strategy, and now it is an integral part of the program. Now, the issues which we face when we talk about TB infection are that, how do you detect it? If you want to treat it, then you need to detect it. So do you have a gold standard test? Right? We understand that we do not have a very clear gold standard test for diagnosis of a TB infection. So that's one problem. The available tests have a poor predictive value. Then you have TB regimes, which are long. So you're using a 6 months regime with INH, which is long and may not be tolerated well every time. And in this situation, the harm versus benefit may not be favorable for most of the population. You cannot treat 3/4 of the population in this way. So we actually talk about shorter TB, shorter regimes for prevention of tuberculosis, and looking at a high risk group which can be targeted, and that group can be treated. And the consolidated guidelines on tuberculosis preventive treatment was published as a module 1 from the WHO. So there has been a discussion on what group you should treat. As I said, it is very difficult to treat masses in India. That's very difficult, right? The tests are not perfect. You can have hepatotoxicity with INH. You have a cost of the drug, and it is not of proven benefit that will it actually help. So what we aim at is a selected treatment where the benefit outweighs the harm. So you need to identify a high risk population where you offer this to help them. Now, previously we were saying that any child who is 6 years and below and has a contact, that child be put on prophylaxis or should be offered a TB preventive treatment. But this data came out in 2018 from the WHO, and this was a systematic review and meta-analysis which was published, and it is quite interesting to see that if you're looking at household contacts, right? So this is the data which talks about household contacts who develop a disease, right? So you're talking about 0 to 4 years, 5 to 14 years, and more than 15 years. So we used to believe that the chances of infection are very high in young children, and we never used to talk about children beyond 5, 6 years of age and adolescents and adults. And if you look at this data and look at the risk ratios, right? So the risk ratios, and this is classified between LTBI positive and baseline, and regardless of the LTBI status. Now, if you look at any of these data, so supposedly you look at data regardless of the baseline LTBI, and in the first 12 months, then the risk ratios are like 25 or 26 in 0 to 5 years. They're like 25 in 5 to 14 years, and again 25 here. And if you look at in 24 months time, they're 15, 6.3, and 11.7, just highlighting the fact that all household contacts are at a very high risk of getting disease. And hence, the WHO came up with a guideline that in countries with a high incidence of tuberculosis, even in children more than 5 years of age, adolescents and adults who are having a household contact with pulmonary TB, which is confirmed, they should be offered prophylaxis. And hence this algorithm was changed. So if you have a household contact, irrespective of age, if you have children over 1 year of age who have HIV, you ask for symptoms of tuberculosis. If they're obviously symptomatic, you investigate them for a disease. If they're not symptomatic, less than 5 years, even if you do no investigations, you should start them on a TB preventive treatment. Now, 5 to 18 years in adults, what the program still says is that you ideally test them and treat them. So which means that if the person actually harbors the infection, it makes more sense to treat them. But again, because the tests are difficult to do and the sensitivity and the specificity is not completely good, it is absolutely fair enough that you put them on a INH prophylaxis if you cannot test them. Now, what do we have with us? Well, most of us have isoniazid, where we use it for around 6 months. The efficacy is something like 65–70% and a very minimal toxicity. Now, what is coming up is a rifapentin isoniazid, also called as a 3-HP regime. It is a weekly regime. Again, the efficacy is similar. The toxicity is low. The main benefit which has been cited is that you can use it every week, which means 12 Sundays you take it and you're done. And then there's a conditional regime where we use 1 HP or daily treatment with rifapentin and isoniazid, which can be considered. But rifapentin is not available commercially as of now. I heard, but I'm not sure regarding the trials which are going on by the government of India, which in some states where they were using a 3-HP regime. And I think Dr. Kabra sir might be having a better knowledge on this, and we can ask him in the question answer round. So these are the doses for 3-HP. I think we can skip them. There's involvement of the private sector as well. We need to link it with the national TB program. We need to notify actually even the contacts. And it is quite helpful because the program is not just giving the medicines, but trying to give prophylaxis and many other things. Now, if you talk about an MDR patient, well, previously we used to understand that if you have a person in their house who has an MDR TB, then usually we used to say that you do not give any prophylaxis and isolation was the only way. But recent data suggests that you can use prophylaxis with some drugs, and we are going to talk about it. And there is a definite reduction in the risk of developing disease. So this is what we have. So if you have someone in the house who has MDR TB and the person has a bacteria which is sensitive to fluoroquinolones, then you can offer them levofloxacin once a day for 6 months, right? But the index, you have to know the sensitivity pattern of the index patient. That's important. Because
Dr. Ankit, Dr. Kamal this side, sorry to interrupt. Can we wind up in next maybe say 2–3 minutes?
Yes, we can, sure.
Thank you.
Not many slides left, right? So you need to know the sensitivity pattern of the index patient, and if it is resistant to INH, as Dr. Tanu was talking about, but sensitive to rifampicin, then you can use rifampicin daily for 4 months. And this has to be introduced in a phased manner in the program. So you screen the contacts. If they are symptomatic, then obviously you need to investigate them for tuberculosis and do accordingly. But if they are asymptomatic, then less than 5 years, you go ahead and initiate a TB preventive treatment. If they are more than 5 years of age, you have an option of test them and treat them. Whether you should use a chest X-ray is something which is not clear, because a lot of organizations believe that sometimes doing an X-ray, you can actually overread an X-ray and create a problem. But most people would do an X-ray in practice. but underreading and overreading X-rays is again a problem. So symptom screening is something which is considered to be the most important rule. So to summarize here, if you have a household contacts, that's one. If you have someone living with HIV/AIDS or an immunocompromised patient in any sense, these are the patients which are considered to be at high risk of developing tuberculosis. Rule out an active disease. Symptom screening is the most important. Doing an X-ray is something which is into practice. What test do we have? We have a Mantu which is there, but again, a lot of people still use 10 TUs, 5 TUs. We understand that the tuberculin which is available is non-standardized. Hardly 1 or 2 TU is available. The cutaneous TB test is still not available. That is what I understand. IGRAs are quite costly. So 5 family members testing, all of them with an IGRA, 2,000, 3,000 is the approximate cost, is not very feasible in all sectors. Test them, treat them. You have 6H, which is most commonly available. Do follow them up for one symptoms, because some of them can develop a disease even on an LTBI treatment, and also look at adverse drug reactions. So TB preventive treatment is one of the key interventions which is recommended by WHO to achieve the NTB strategy targets. The benefits have been extended to all household contacts of pulmonary TB patients. So that's important. We, invariably every week would see a patient where someone in the family had tuberculosis, and TB preventive treatment was not offered, and that person develops a disease. So I think that is a very important thing which everyone should understand, that it is now not restricted to less than 6 years of age. It is now expanded to all household contacts. We have shorter regimes which are underway, but in clinical practice, 6H is something which we offer. So thank you very much, and I'll hand over to Dr. Kamal.
Thank you, sir. Thank you so much. I think we will straight away start with our next presentation. I will request Professor Kabra here to give his presentation on where do we stand as of now as a country when it comes to NTB 2025. Professor Kabra, please.
Respected chairpersons, moderator, and friends, the topic assigned to me is where do we stand as far as NTB 25 is concerned. So I'll be talking about what are the targets and what are our achievements and reasons for not able to achieve the targets by publication in India and abroad, and personal experiences, and then what is the way forward. So let us see. The WHO NTB strategy 2025 milestones were that the incidence rate, we need to reduce it by 50% from the baseline of 2015. And what is our achievement in the world? 8.7% reduction. Instead of 50%, only 8.7%. And number of TB deaths, our target was that it should be 75% reduction, while we have achieved only 19%. And percentage of people with HB facing catastrophic total cost, that is, the people are spending a lot of money and going below the poverty line, that should be 0, suggesting that all the people should get the anti-TB drugs free, but still half of them are getting, half of them are not getting. So there is a significant gap between the target of incidence, deaths, and percentage of people with the TB facing catastrophic total cost. Then let us see that in 2018, UN high-level meeting on TB treatment targets were that TB treatment for all should be started in 40 million patients all over the world, and it was started in 34 million. We could achieve up to 84%. And treatment of children, it was, to target set was 3.5 million, but we achieved only 2.5 million, around 71% of the total burden. And MDR-TB treatment for all age group, target was 1.5 million, and between 2018 to 22, and we achieved up to 55%. And MDR-TB treatment in children, as Tanu has already pointed out, it is very dismal performance as far as children is concerned due to various reasons, and only 10% the target was achieved. Then another one was TPT, as Ankit already pointed out, that there are certain problems in it. And the target was that by between 2018 to 2022, 39 million targeted 39 million, while we achieved only 15.5, that is 52%, less than around 50%. But if you see the people living with HIV, it was more than 100. It was 100%. And the problem is if a child is household contact below 5 years, we could achieve up to 55%, and contact of more than 5 years, it was only 10%. So we performed better as far as below 5 years of age is concerned, but we were not so good in above 5 years of age. Then the funding target, that is that the UN body suggested that there should be a help of $13 billion in 22, but it was only 5.8 billion, that is less than 50%. And same thing is for the TB research. Instead of 2 billion, only 1 billion was available, and that was 50%. So this is for the world. Say case notification of TB, newly diagnosed with TB in India. All these reports are from the Global TB report and India TB report of 2023. And you can see here that from 2015 onwards, there was constant increase in the reporting notification. But in 2020, there was a steep decline. And subsequently, good thing is that we could achieve back in 2022 more than what was expected in 2019, 2020. And you can see that what the COVID has created a trouble, that this is the mortality. And you can see there is an increase in the COVID-related death. This is for all age group. COVID-related TB, more TB deaths. So definitely there is a gap between the target and our achievement. Then what are the reasons? So I have selected 3 papers recently published in which Central TB Division people were also part of this study. And you can say one is situation analysis for TPT. And this was a mixed method approach to conduct a situational analysis of initial phase of TPT implementation among household contacts of pulmonary TB patients in the 3 districts of Delhi. And results were that organizational structures and planning were established. This was good thing. But implementation of TPT was suboptimal, with issues in the drug availability, procurement, budget, human resources, and training. Awareness and motivation and sorter regime, telephonic assessment, and collaboration with NGO emerged as we may be able to perform our enablers. Barriers were apprehension about taking TPT, erratic drug supply, long duration of treatment, side effects, overburden, large population, and a possibility of INH resistance in the range of 10 to 14%, data entry issues, and private providers' reluctance emerged as barriers. So conclusion was, while progress has been made in TPT implementation, there is a room for improvement and refinement across various domains. I selected this paper because it was published recently, only last month, and TPT, as Dr. Ankit pointed out, is one of the mainstay of one of the main tool for control of TB. Then you can see here that the barriers were multitasking, lack of training in the TPT, supervision and monitoring challenges, and personal conviction regarding INH resistance. And other problems related to the program was drug supply and procurement challenges, time of the NICSA ID and NICSA program, human resource shortage, data entry and system issues, large population to cater, lack of convergence between the sectors, prioritization of the other services, and private providers' reluctance. It is again summarizing that what are the barriers and limiting factor for TPT. Then another one is this patient's unmet need of a resistant tuberculosis. And this was to identify, this was study carried out in Pune and published last year to identify and describe the unmet needs of patients with multi-drug resistant TB. And it was interview of 128 patients. Barriers were delays in diagnosis. As we can understand that a patient comes to a physician, he makes suspect and makes a diagnosis. He sends the sample, sometimes may have to get it from the private laboratories, lack of counseling, late referral to the NTEP, and unwarranted expenditure. Unwarranted is that the patient has to spend out of pocket because some of the time these tests are not available easily. NTP care centers providers dismissal of the symptoms, non-courteous behavior, lack of hygiene in the referral centers, forced stay with the other patients, and lack of support for the psychological and psychiatric problems. So conclusions were attention to patients' several unmet needs can be improved in MDR-TB care. These include educating private providers about MDR-TB risk and available rapid molecular assays. At the RNTCP NTEP, training health workers to build rapport with the patients, maintaining hygienic environment with adequate isolation of the participants with MDR from other serious cases. Referral of the patients with the psychiatric symptoms to mental health specialists and monitoring drug shortages. Then is there a scope or existing facility can be utilized optimally? So a partnership under NTEP was established to strengthen the TB laboratories, and 61 culture and DST laboratories were added, and this has a capacity of 200,000 liquid culture and 170,000 molecular DST annually. The laboratory networks were operating at 69% of efficiency, and there is a possibility that there may be enhancement of these services, like liquid cultures can be 450,000 and first line DST 180,000. As all of us are aware, these tests are not available easily. So additional capacity is there. It needs that there should be will for the managers to increase it. So personal experience is the technical aspect, the technical report guideline is excellent. It includes all these things. But for pediatric patients, my personal feeling is that MGIT culture should be carried out in all the patients because the samples are very precious. And diagnostics or easily available samples should be accelerated, like a stool sample, urine sample, other body samples. And it is mainly the operational aspects. Lack of communication with DOS center. DOS center people, they are, whatever is their experience or whatever is their qualification, they just remain a supplier of the drug. Erratic supply, diagnostic as well as drugs. Lack of system for recording and reporting side effects. No counselor for the TB patients. It is very important that these patients require a good counseling so that the targets can be achieved. Healthcare facilities are not child friendly. As in the public sector, fixed days, it may be, say, my OPD days are Wednesdays and Fridays. If patient gets some problem on other days, they are not being entertained. Poor OPDs, IPDs, and provision for acute care is not there. To whom to contact if someone is having a problem? Changing daily, there is some change of the healthcare workers, doctors, residents, and continue the same treatment remains. This is a typical of a public sector. Even in the private sector, there is no responsive people who can take care of their problems. As we do some treatment for the fancy diseases, but for a common illness like TB, we do not have a psychological support, we do not have a daily or some acute support. What is the way forward? First and foremost is we accept the suboptimal performance and review the barriers. Revise and restart working on these to achieve targets. Strengthen the feedback from people working with the patients and in the field rather than people making the strategy without knowing the field's problems. Immediate action on the feedback received and communicate action taken to stakeholder, irrespective position of the stakeholder. If it is some problem is raised by a nurse or a field worker, it should be taken seriously. Active actions to reduce procedural delays, make all stakeholders partner in NTEP, and we work towards achieving our targets. So this is UN body has revised the targets now. They have fixed 2027 as the target to reduce the incidence and all these achievements. So where do we stand? To summarize, I am very optimistic because highest level of our executive, that is Prime Minister, heads on commitments. And there is a significant achievements as far as pediatric TB is concerned, but there is a gap between target and achievements. And as I am witness to actually seeing this pediatric TB for last 3 decades, there are significant achievements, but gap still remains, and there is a scope for improvement. Reasons for underachievement is technical aspect. It is the nature of illness, no effective vaccination, and difficulty in diagnostics in children. Operational aspects, maintenance of supply chain, because this is mainly the guidelines prepared by the Central TB Division is excellent, but operational aspects are lacking. And there is a maintenance of supply chain, poor communication between the care providers and managers, less funding. And to some extent, COVID-19 pandemic was also responsible for underachievement. Way forward is accept our weakness, revise our targets and strategies, make all stakeholders partner, establish two-way communication between the care providers and administrators, and increase funding for care and research. Thank you very much.
Thank you so much, sir. As always, your presentations are a good source of learning how to be crisp and finish on time. So we have a list of questions lined up with us. I think first I'll request Dr. Tanu Singhal. There is a question that when you suspect primary versus secondary drug resistance, how do you approach such a patient? Based on examination, radiology, what will be the pointers which will tell you that this is primary or secondary? Is there anything there, or how should you approach?
No, so secondary drug resistance means that this child has already been taking treatment for TB and then has treatment failure. So that would be a pointer that it could be secondary drug resistance. Whereas primary drug resistance, you would think in a child who's non-adolescent or whatever be the age, who has come with TB for the first time, has no history of exposure to TB treatment earlier. And it is important because if the child has already, if we're diagnosing secondary drug resistance, that means the child has already been exposed to many drugs before, and therefore our choice of regime may be different. But otherwise, it's history only which will tell you whether it is primary or secondary.
Perfect. So history tells you whether it is primary, but on examination, on radiology, there are no pointers which can differentiate between these two. That was the question. Secondly, if what is the youngest age at which you can give bedaquiline? And in newborns, if suppose you have to give, what will be the alternatives if you cannot give it?
So, as per the government, bedaquiline can be given above the age of 5 years. But in Mumbai, we have been giving it off-label in children below the age of 1 year. I don't have experience with giving it to a newborn. But I guess in a very young baby, you would replace bedaquiline with an aminoglycoside. That would be the way to go. So you would use even the program says that all the regimes where you have bedaquiline, if the age is below 5 and if bedaquiline cannot be given, you replace it with an aminoglycoside or another group C drug.
Perfect. There's a question that if you are treating a patient with a pleural TB, when do you expect response, clinical response? What would be clinical response to you, and when would you start working for drug-resistant TB in such patients?
So this is a big dilemma because pleural TB, it is difficult to establish the the microbiologic diagnosis because most of the times the pleural fluid NAT is negative. So you start treatment empirically for first line, and by 4 weeks, you should start seeing a response in the form of resolution of the fever, the chest pain, and weight gain. I don't think you can look at radiological response to guide, to differentiate between response and non-response because the effusion may take a long time to go away.
Thank you.
But
So
yes,
which means, yes.
But yes, by 4 weeks, if you're not seeing a clinical response in terms of resolution of fever and starting of weight gain, you would start working up the patient. And in such a patient, because you had done a pleural tap initially and your expert was negative, you would probably try and get another sample with a higher yield, like you would probably do a pleural biopsy to make a diagnosis.
So we do not have to just chase the radiological shadows, look at the patient holistically and completely. What about this test TB Sure, which is being marketed by some private labs? How sure are we of this TB Sure?
Please let the other panelists enlighten on this, but I don't know about this test. And one more thing, which I made that point earlier, that please always ask for the NTEP approved tests only, because there are many private labs who, for cost reasons, are doing open PCRs and other things. So I think you should just go for the NTEP approved tests. Ask for Gene Expert, ask for TrueNat. And if in the private sector, you can also ask for Expert Ultra.
So I'll put this question straight across to Dr. Kabra. Sir, this TB Sure, and there are many tests which are there available nowadays coming up, which are not WHO approved. So your take on this, sir?
Yeah, I totally agree with Dr. Tanu that there may be multiple tests available with the multiple names, and we should use only those tests which are approved by the NTEP. At the most, we can diverge a little bit to use ultra, but not the other tests.
Thank you, sir. Next question to Dr. Ankit. Sir, IGRA versus MANTU. So how do you, there are some states which are promoting IGRAs. There is a question. So how do you weigh MANTU versus IGRA? Can it replace it? Should it replace it? Why it should replace it?
So I think there was a very clear guidance by the WHO and by the National TB Elimination Program that IGRA is technically complex. It is definitely more costly, and it is not a point of care test. So we should not replace MANTU with IGRA. So I think that point was very clear from the programmatic point of view. So you cannot replace a MANTU with an IGRA, right? So I think that has been the take of every one of us, that you cannot replace it. You occasionally can use it in your practice in some circumstances if you're really worried about a latent infection and you want to treat it or you don't want to treat it. So in some circumstances you can use it, but they're definitely more costly, and for the general population you cannot replace it.
One question is regarding the regimes that you have suggested, the 6H, the 3HP, and 1H. Other than these, are there any other regimes available? Especially for the private sector, which one of these is the rifampicin available? I know you have touched on this in your presentation.
So I think we're very clear. We follow the national guidelines. It is 6H. That is what we follow. I don't think so rifampicin is available with us at the moment in the commercial market. Kabra sir, do you have any clarity on whether it is available in the program?
So as there are 3 regimes, first is 6 months of isoniazid for all age groups, and it's available. Second is 3 months weekly rifampicin isoniazid, and that is after age of 2 years. As of now, the company is not providing it. Central TB division is trying to gets DG permission to get the drugs for only programmatic use. So I don't think it is available commercially, and it will be available commercially. So it is after 2 years of age, and it should be shortly available. Third regime is 3 months of isoniazid and rifampicin. So it is not being recommended as of now uniformly for all because of the concern regarding if we use rifampicin, then it may produce more of a MDR regimes if they become resistant to it. Though some of the states have used it only in a selected population. So as of now, it is not recommended to use 3HR. And the last one, like if it is a isoniazid resistance, then you can use 3 to 4 months of rifampicin daily.
Thank you, sir. Sir, there is a question that AIIMS Delhi is starting adult BCG vaccination. What is the reason behind that?
It is not a service or a clinical care. It is part of a research project that a multi-site research project to prevent or control tuberculosis. BCG revaccination is being tested, and it is not the service or recommendation. So wait for result of this trial if it is really decreasing the tuberculosis.
So any of these diaskin tests, CTB tests, anything which is going to be, there are questions about these ones in the chat box.
CYTB or CTB,
Yes.
these are specific skin test, which is in vivo IGRA based test, in which there are specific antigen which is specific for the Mycobacterium tuberculosis. It has been approved for use in children above 18 years, in persons above 18 years of age. There was discussion that whether it can be approved above 5 years of age. Probably it should come very soon that it will be approved. So this is as compared to it, obviously it has some advantage as compared to the TST or MANTU test. And if it is available, possibly it may add to the identification of TB, tuberculosis infection, and may be used as an adjunct for the making the diagnosis of tuberculosis.
Thank you, sir. Dr. Ankit, whether MANTU can differentiate whether it is the positivity is because of vaccination or infection? How do we look at it? Somebody who has had an infection or somebody who has had a vaccination, how to read this MANTU?
So I think, see, you have any MANTU does not distinguish between infection and disease. So that is one thing which we have to understand. You also need to look at symptoms simultaneously, right? So if you're trying to look at only a latent infection versus whether this MANTU is positive because of a BCG, then you have to look in terms of the clinical context. If the child is actually exposed to disease, to a household contact, then irrespective of the MANTU, the child requires prophylaxis. But it may be sometimes difficult to distinguish whether the MANTU is positive because of BCG or not. That is sometimes can be difficult. I think IGRA is definitely more useful in such situations.
Thank you. Dr. Tanu Singhal, what is the prognosis in patients of MDR, the patients living with HIV and who have MDR? So there is a comment that very, very harsh comment that they usually either die from drug toxicity or delete. So your take on this?
So I would say that the prognosis of MDR TB is worse than drug sensitive TB, and the prognosis of MDR with TB with HIV is even bad. But currently it's not that bad. I mean, unless the patient comes with very low CD4 counts and you have now good drugs available. So it's not, I don't think you can give up on such a patient. You would have to treat, and currently with the current regimes that we have in MDR TB, at least without HIV, treatment success rates of 80 to 85% have been reported.
So the things are not so bad after all. Thank you. One question again for you. When it comes to abdominal TB, and microbiological diagnosis is not possible at times with all those needles and pricks. So how do you go about treating such patient, and when do you consider MDR in such children where specimen is not available?
So, I mean, unless the patient has any risk factors for MDR-TB, you would evaluate these people. You would make sure you're not dealing with inflammatory bowel disease, which is a very close differential of abdominal TB, and then start them on first-line treatment. And then, as I said, if after 4 weeks these patients are not improving, then you would either consider the alternative diagnosis like Crohn's, which is a very close mimic of abdominal TB, or drug-resistant TB, in which case you would even do an invasive test to make a diagnosis. Like, so if it needs that you do a laparoscopic biopsy of a node or the omentum, you would go ahead and do that before you actually think of switching to an alternate regime.
So the point is that even without a microbiological diagnosis, given a particular scenario, there is a place for starting MDR-TB treatment or no? That's the...
So that is provided you have made efforts and you
Yes.
have ruled out an alternative diagnosis. I think that is very important.
Yes.
We have seen patients with treated as TB turning out to be lymphoma. We've seen patients with abdominal TB being treated and not getting better and turning out to have Crohn's. So I think you have to be very careful because why? You can start your first line treatment empirically because you have done your gastric lavage and all, it's okay because the drugs are not toxic. But second line drugs are hugely toxic, expensive, not easily available. So you have to be very careful. So if you have made all the efforts and yet you can't reach diagnosis and you're made sure you're not dealing with an alternative case, then you call that probable MDR-TB and you can start treatment in these patients.
Thank you. Now the question for Professor Kabra. Sir, what is the effect of COVID on chest radiology? So post-COVID, are there any the X-rays that you are seeing, are they any different? Or the pulmonary TB, is it any different before and after COVID?
So when there was a COVID, there was a lot of problem and confusion regarding what may be the cause of these shadows on X-ray. Though it was not so common for pediatricians, but it was more problematic for the adult physicians and pulmonologists. As far as COVID is concerned, it would be more of a peripheral lesions along with a ground glass appearance. While in TB, it's different, but there may always be overlap of 2-3 things together. And some, though rarely, but many unusual forms of X-ray abnormality has been reported, including some having a nodularity all over, predisposing for the this hematogenous spread and so on. But there is not so much of a confusion about TB and COVID. There may be some overlap of a viral infection and TB.
Thank you so much, sir. I think I will thank all the experts, Professor Kabra, Dr. Tanu Singhal, Dr. Ankit Parak, for all the time they had given. And to the chair for the session, Dr. Kalpanavar, sir. Dr. Jagdish Goel, I think I'll hand over the reins to you.
Okay,
over to you. Thank you so much. Thank you.
Sir, just a last question, Kabra sir. This question is from Rawat sir. Is Government of India is considering to revise the target of NTB by 2025? This is the last question.
As of now, I have not heard about any meeting conducted for this thing. But obviously, going by the and even the TB report of Government of India is silent on this thing, that how much we have achieved and how we can improve on this thing. There is a use data and reporting that what we have achieved till now, but what are the barriers and how we can improve on it. But I feel that all the stakeholders, including central government as well as pediatricians and TB care providers, will work together, and we may be better off, though we may not be able to achieve the set target by 2025. This is for the government. I hope they'll revise this thing.
Thank you, sir. So on behalf of IAP National Respiratory Chapter, I would like to thank all faculty member, moderator and attendees. And we would be having pediatric pulmonology clinic on this Monday, 25th of March at 9 p.m. Wish you all very happy Holi. And with this, we conclude this session. Thank you very much. Good night.
Good night, all.
You, good night.
Thank you.